Next, I want to introduce Dr. Adolfo Rubinstein. Dr. Rubinstein is a physician who graduated from the University of Buenos Aires. He received his master's in clinical epidemiology from Harvard School of Public Health and DRPH in public health from UBA in 2000. In 2002, he obtained a diploma in health economics at the University of York, UK, and in 2022, he completed the executive program of implementing public policies at Harvard Kennedy School of Government. Dr. Rubinstein is a full professor of family medicine, full professor of public health, and founder and former director of the master's program in clinical effectiveness at UBA. He's also a visiting professor of the Lone cardiovascular program at the Harvard T.H. Chan School of Public Health. Please join me in welcoming Dr. Rubinstein.
Okay, thank you, Maria, for inviting me and for this opportunity to present my experience and my thoughts. Probably I will give you a different perspective of implementation science, maybe more a policy perspective rather than implementation research perspective. But the main challenge, and the big challenge, is how to get together these two worlds, the world of researchers and the world of policymakers. And I will try to talk about that. So most researchers, maybe some researchers, think maybe naively that when you publish a paper, and particularly in a high impact journal, or because of a natural passive diffusion of information, you get to changes in policy and practices. I mean, most of the researchers, but not anyone from this audience, of course. And this is a natural process. So if I can publish in JAMA or in New England Journal of Medicine, okay, I mean, this piece of evidence will disseminate across the world and will change naturally the policies and the practices. Why is that? Because we think, naively, not you, that scientific evidence is the most important driver of these changes. And there is not any other colloquial evidence that may change, that may be more or even equally or even more important than research. But look at this. There are a lot of colloquial evidence coming from, oh, I'm sorry. The laser point is, right. So you can see politics, and I will talk about politics, values, attitudes and beliefs, interest groups, the stakeholders. I mean, we name a lot stakeholders in the previous talks. Ideas and ideologies, the media. So a lot of colloquial evidence that are equally or even more important than scientific evidence. And of course, it depends on how strong is the science behind the finding. And what is the influence of scientific evidence in the whole process, in the whole decision-making process? We can start from decisions on clinical practices, which have a more linear, a kind of a more linear model of relationship between evidence from research and implementation. Suppose, in the clinical practice. So, and that's beyond the barriers that are there between efficacy in clinical studies or RCTs to effectiveness in the real world. But there is a linear model. But when you go further to decisions on healthcare or other organizational settings, and look at the inverted pyramid at the right-hand side of the figure, of the slide, there's a weaker relationship because the implementation of services, health services, is usually multidimensional and is very sensitive to the influence and power of the stakeholders involved. And thinking, when you are talking about large policies, what I would say the big P policies, well, the influence of scientific evidence is minimal because it's very strongly influenced by ideologies, values, power relations, interests of different actors, financial motivations, economic theories, ease of political implementation, or fashions or whims of politicians. So there is even increasingly difficult to move forward interventions, programs, and policies in the real world if you don't talk to policymakers or the relevant key stakeholders. So looking back at the first slide, you come from research, but to go to adoption, implementation, even scaling up at the health system level is part of the journey. It's like an intermediate station. So to really make changes in policies and practice, you have to engage key stakeholders. But to engage key stakeholders is not just, well, where are the stakeholders? You have to map. You have to map their influence, the power, the positioning, the interest. And when you map the stakeholders, you have to create, you have to do a political analysis and develop a political strategy. And when you develop a political strategy, then you have more chances, more likelihood to remove the barrier and get to changes in policies and practice. This is another bridge. So I think this is a third or the fourth bridge. But it's the same. We all know, particularly here, that interventions that prove to be effective in clinical and control research settings are not implemented in the real world. And how to cross that bridge? What do we have to do to cross that bridge? Because look at the gears. You have the clinical research articulated with implementation research at a small scale, and how to get to policy change if you want to really adopt and implement a large scale, a big policy. And again, you have to take into account to consider the stakeholders, the political context, the healthcare context, the ideas, the interests, the agents and institutions, and the ideologies. We change very, very, very often. This is a statement, a phrase in my WhatsApp. No plan survives to the first contact with its implementation. So what I want to mean, you cannot plan what you don't know well. If there are a lot of unknowns, and implementation is a complex challenge, planning is not enough. And Vilma and many others said, before, that you have to consider, you have to be flexible, adaptive, innovative, disruptive, and that's implementation. And again, implementation strategies, again, a definition, have been defined as method or techniques developed to change practice patterns within a specific setting to enhance the adoption, implementation, and sustainability of evidence-based health interventions. I think that we know that, but how to get the real change? What is the color of this dress? This, I remember it 10 years ago or something. Remember this figure? Raise the hand, those who see that the dress is blue and black. And raise the hand, those who see as white and gold. And how is that? Is it possible? So half of the audience see this dress as blue and black, and the other half white and gold. What happened with our eyes? So this is just a metaphor of, because researchers and decision makers not only live in different worlds, but also see, understand, and act differently. They have different jargons, norms, everything is different. Understanding. Researchers, so us, I'm still considering myself as a researcher, don't ask the questions that decision makers need and don't exactly answer the question that decision makers ask. Take a long time to get the jobs done because they do not have elective times. We were talking with Martin about this. Do not report results in a way that is easily understood by policymakers and do not usually know how to translate their findings into policy and practice. So this is the challenge that we have to learn or we have to teach. Do not understand that the formulation of a policy is just an intermediate stop in the journey. So it's not just scaling up the intervention or the policy of the program at the health system level, it's go beyond, further. On the other hand, decision makers have limited resources and little time because they have a competitive agenda. They can handle 4 or 5 issues at the same time. So and if you want to put that into the window, if you want to put your issue, your problem in the agenda, well, you have to persuade the policymakers different. Do not usually understand that the answer to their questions may require research. Demand immediate results and do not usually tolerate uncertainty. So if you talk about confidence intervals, you will be dead. So this is another framework, but to make life easier for Martin, where's Martin? This is very simple. This is very simple. This is the multi-stream framework of kingdom. Vilma talked about that. So 3 streams. The problem is the objective issue, which is causing some concern in the policymakers, the public at large, the society. That's the problem. We have to do something. It's not the problem that we can consider as epidemiologists. It's a problem that is getting, worried to policymakers or the society. The policies, well, is there any existent solution to account for that problem? So the policy is a tool. And the politics is a flow of interactions around the elaboration of that policy. So when the 3 streams converge according to kingdom, and there is a lot of empirical evidence, when the 3 streams converge, you can open a policy window for implementation. But that's not enough either. So you have to put the issue in the agenda. And when you put the issue in the agenda, there is a lot of stakeholders that will start interacting with their position, influence, interest, power. And you will get to compromises, maybe things that coming out in the policy or in the intervention are not the same as the things that came in. And finally, the implementation, because you can adopt an intervention, a policy at a national level. Maybe there is a law or a clinical guideline, but does not mean that this will be implemented in the real world. You know that. So there are 4 factors that determine the feasibility of policy change. The players, stakeholders, which are the set of individuals and groups who are involved in the reform process and might enter the debate of the policy fate. The power, the relative power of each player in the political game, the position and interest, taken by each player, which are supporters or opponents of that policy, and the perception, the public perception of the policy and the player. And when you plan and when you develop the political strategy, well, you have to think in, well, can I change the power of the supporters and opponents? Can we change the position, which is more difficult? Can I get more players, more supporters into the arena? Or remove some opponents? Can I change the perceptions? And the perception is a question of data, but also storytelling. And let me just sorry. And what yeah. Yeah, to the policy side. Thank you. And what Valerie said before, when she presented the first slide on cervical cancer incidence in Peru compared to the rest of Latin American countries and the world, that is very powerful because she presents data, but she also presents a narrative, a storytelling, how many women are dying because they don't have an acceptable screening rate or treatment rate. So when you go to the policy life cycle, you have the policy first, the scientific evidence. Which is the influence? What's the influence of the scientific evidence? It depends. How strong is the evidence? Are there many opponents? Who are the beneficiaries in terms of public perception? That is important. And that will shape the influence of scientific evidence. But from policy formulation to policy adoption, there are a lot of compromises among stakeholders. This is the flow of interaction, the political interactions I talked before. And even between the policy adoption and policy implementation, there are a lot of barriers because of not only because of veto points, but also because designers and implementers are not the same people. In general, those who design the policy, the intervention, the guideline, are not the same that who have to implement that policy. So, and this is the truth. Laws, like sausages, cease to inspire respect in proportion as we know how they are made. And this is true. And we have to tolerate that. Maybe things that come out are different from things that came in. Let me finish with a personal story. So this is late-breaking trial session in the American Heart Association meeting in November 2016, so 8 years ago, less 7 years ago. And you can see Vilma, me, and Dr. Jian He. We were running an implementation science trial on hypertension control in Argentina. It was a very, very, very successful trial. Multi-component intervention with all the theories, frameworks, and models that Vilma presented in the first session. And imagine how proud we were. 1 year later, when this paper was published in JAMA, I was Minister of Health in my country. So I was like in both sides of the counter, as we say in Argentina. So when I presented the trial in the meeting, I was an implementation researcher, and I remember having talked to Vilma about how are we going to engage policymakers? And 1 year later, I was a policymaker. I was the national authority, health authority. So this is just because I mean, the planets were aligned. And of course, it's very uncommon, even for other countries, to have a implementation researchers as Minister of Health. But this was something that happened. And at that time, well, I had to think how to do that. How to do that. And let me tell you that at that time we had a 500 million budget for prevention and control of chronic disease in Argentina. So, finishing with a Confucius statement 2,500 years ago, tell me and I will forget, show me and I may remember, involve me and I will understand. Thank you.